So in terms of the looking at where I select the best frontline EGFR TKI for my patient, I look at several different characteristics. So there's a number of approved options first line. You have Erlotinib, Afatinib, and now Gefitinib is back and approved here in the United States. And there's also some promising data looking at adding bevacizumab to Erlotinib in terms of progression-free survival in a Japanese population, but the data hasn't yet been presented yet and is still ongoing in terms of in a non-Asian population. So in general, my approach is my standard EGFR TKI has been Erlotinib, and I think that's for many doctors in the community. Erlotinib is something that they're familiar with and have used for a number of years and feel comfortable with in terms of managing the side effects and the dose reductions and so forth. In terms of Gefitinib, it generally it may have more modest side effects. And maybe a bit better tolerated. So for example, in older patients, I call them kind of my little old ladies who have EGFR mutant non-small cell lung cancer, I used to give them Erlotinib 100 milligrams daily, start with a dose reduction in terms of mitigating potential side effects in terms of people who are older may have some compromised performance status, maybe much smaller than your average patient. Now I think for those patients, Gefitinib is a very reasonable option. So that's something I look at for those types of patients in terms of having a manageable toxicity profile. So that's where I, in my practice, have used Gefitinib. In terms of Afatinib, there has been some data looking at patients with EGFR exon 19 deletions with a pooled analysis of the Afatinib versus chemotherapy Lux Lung studies showed that there was an overall survival benefit of Afatinib versus chemotherapy, whether that's an artifact of the trial designs or represents something real compared to other EGFR TKIs. It may be more the former than the latter. I think it's unclear, but I do discuss with my patients who have EGFR exon 19 deletions who are very fit the possibility of using Afatinib rather than Erlotinib based on that data. So Afatinib binds more potently to EGFR, both mutant and wild type, so there tends to be potentially more rash. There's paronychia, some stomatitis, so this is a little more intensive side effect profile. But I do discuss it, so I balance that with this potential for a modest benefit over other EGFR TKIs. For example, in the Lux Lung 7 study that compared Erlotinib to Gefitinib, there was a modest progression-free survival benefit. So I do discuss this with my patients, and it's something that I look at for patients with EGFR exon 19 deletions. The fact of the matter is, as long as you put them on a frontline EGFR TKI, if they have an EGFR activating mutation, these all three are NCCN category 1 recommendations. I generally start with Erlotinib, and there's also some provocative data with a several-month progression-free survival benefit adding bevacizumab. So that's something I've talked about with patients. I know some practitioners do it more than I do. I have not added bevacizumab very much as I'm waiting for additional data from non-Asian patients with EGFR mutant lung cancer to come out and be presented and published. But I do think that that's also something that has been used more and more and can offer a potential progression-free survival benefit balanced with the added toxicity of bevacizumab and the need to not just do an oral daily medicine, but have an every 3-week infusion. So in terms of doing repeat molecular testing in patients with EGFR mutant non-small cell lung cancer, I think that's really become standard of care now because we have an approved EGFR tyrosine kinase inhibitor, osimertinib, that's active against the T790M resistance mutations, which represents about 50 to 60% of resistance of the PI for resistance for EGFR mutant non-small cell lung cancer that's progressed on a previous generation EGFR inhibitor. So I generally obtain molecular testing on these patients, on every patient that develops resistance to a first-line EGFR TKI.